Okay, good afternoon. It's really a pleasure to be here, and I'm going to be shifting gears slightly from this morning's discussions and to talk really about what is happening on the front lines. And one warning or disclaimer I'll give you right away is what's happening on the front lines is way far behind many of the things that I've been hearing about earlier in the day. So in the clinical setting, as many of you know, we're still really catching up with many of the changes that have been thrown at us. And so I think that's an interesting discussion for us to have here. So here's just our learning objectives for this talk, and I have no conflicts of interest to disclose. So before we talk about how genetic counseling and genomic counseling is changing, I first thought it would be worth throwing up a definition for those of you who aren't familiar with what the process is. And it really is, this is a definition from the NSGC website, that's our professional organization. And it's really the process of helping people understand and adapt to the medical, psychological, and familial implications of genetic contributions to disease. And in order to do this, we do quite a few things. First, we collect a lot of information from individuals about their family and about their medical history. We do a risk assessment, which is very largely based on interpreting the family history, but also interpreting genetic test results in conjunction with the laboratory and the physicians that we work with. We do a lot of education of the patient and their family members about the condition of interest so that they kind of understand the natural history of the disease and what they might expect. Informed consent is obviously an important component of what we do as well, obtaining this when genetic testing is ordered or when any type of research study is offered. And then I think one thing that does set us apart is we have training in psychosocial aspects of medicine, offering psychosocial support to families as they go through the journey of kind of learning about their genetic condition. So that's kind of what we're known for, what we do. And a lot of these recent disruptive changes have really turned what we're doing on its ear. And I think that we can all agree in this room that being in genetics in today's day and age is really exciting. It's a constantly changing field. It's one of the reasons I love my job. And it's really because of some of these recent disruptive changes. And certainly these aren't things that are new to any of you. And this certainly isn't an exhaustive list. But just with the explosion of gene discovery and characterization, the direct-to-consumer genetic testing companies really increasing public awareness around genetics, which I think is a positive thing, also has increased utilization in many ways. And then obviously the technology that we've heard a lot about over the last couple days with next-generation sequencing and other technologies that have made tests that were formerly very scary to patients, like an amniocentesis, much less scary because they can just have this test done with a blood test. So, and there are pluses and minuses to that. I was laughing because when I did a little search about disruptive change, I found this image, and it made me laugh because I think depending on which professional society meeting you go to, you can see a kind of a lopsided distribution of how people respond to these types of external disruptive changes. I feel like at this meeting, and I don't want to pigeonhole everybody, but I feel like change initiator, change junkie, there's probably a lot of you in the room, or you're at least change receptive because you're here learning about all of this. But I can tell you that as things trickle down into the clinic and we're sitting with the patient, the change phobic stuff starts to come out a little bit. And so I think it's worth having an open discussion about that, about how disruptive change trickles down into the clinic, not only for the clinicians, but also for our patients as they're hearing this information. So you've probably seen a slide like this at this meeting and others, or some version thereof, where we talk about changes in genetic testing and then and the now. And I'm not going to belabor this issue, but I do think that in my area of expertise, which is cancer genetics, we still haven't really ventured wholeheartedly into the whole exome genome sequencing world. We're still kind of stuck at the multi-gene panel stage. But even that for us, I can say, was a pretty shocking transition from only really being able to order tests for a single gene or condition at a time. And I will say that while that was driven not only by really using the family history as a tool to assess what the patient might be at risk for, it was also driven by external factors such as cost insurance coverage. And if you're doing genetic testing one gene at a time at about $1,000 to $1,500 a pop, by the time you hit your third or fourth gene, getting the patient or the payer to pay for that is somewhat challenging. So I think there are many external forces that make this a very complicated issue. So there have been a couple reviews published about the differences between genetic and genomic counseling. And these really focus on what are the similarities and what are the differences. And one of these was from Kelly Ormond, who I believe gave a similar talk last year at this meeting. And I liked how Kelly broke down the changes that will impact our transition going from genetic counseling to genomic counseling. And she broke it down into these three kind of buckets, scope, approach, and process. I want to touch on these each a little bit. So scope is pretty obvious when you're doing a single gene test versus a whole genome. Obviously, the scope is much bigger, but there's a lot of downstream effects from that scope increasing. One is that there's a higher likelihood for variants of uncertain significance and or incidental findings. The depth and breadth of information to be shared with patients. And if we are going into this thinking that patients need pre-test counseling, which I think I've heard a lot of debate about here at this meeting, it's been interesting, then how do we do that efficiently? And can we do that efficiently? Or do we really need to change our service delivery model and how we're thinking about sharing information with patients? You need a lot more time to interpret results. I remember hearing a counselor who worked for a lab who did whole exome or whole genome talking about at the very beginning how going through one variant at a time was taking about 2 to 3 hours per variant just for her piece, and she was only doing part of the work. So obviously that's not realistic in terms of sustainability. And then as we all know as clinicians, there's a paucity of data on many of the variants that we see, even the genes that we see on some of these panel tests, as well as the conditions themselves. In terms of approach, we are relying, if you're really just going to do a shotgun approach, you're relying a little bit less on the condition-specific testing, at least at the front end. One of the things I think that's interesting is I heard somebody say that it's important to take a family history before you do genetic testing, but if you're doing whole exome, whole genome, it's also important to revisit that history after in light of the results that might have come up on the test, because sometimes people won't remember parts of their family history, or going through whole genome sequencing might make them go back and dig a little deeper and say, oh yeah, this sudden death did occur in my family, I didn't even know about it. This might explain why I have a variant in this particular gene. There's also a balance that needs to be struck between increased uncertainty of results and the need for information. I think that in my personal experience, the number one reason why patients decline a cancer panel versus a targeted test is uncertainty. They're not people that deal well with uncertainty, and that's a very uncomfortable concept for them to think about. Certainly that's not probably going to be a problem for those who are pursuing 23andMe and other types of DTC tests, but within the clinic, that can certainly be something that we see. So I feel like when I'm talking with patients now, I'm spending a lot less time on the specifics prior to testing, really doing a much more broad strokes approach. And I'm doing a lot more discussion on the back end, where once results are available, talking to them about the specifics of what we found. The other shift I think we're seeing, and the concurrent session I was just at was talking about doing predictive genomics. So it's really genomics on the worried well or the healthy person, really to shift our focus away from diagnostic approaches and more into preventive approaches, which I think is wonderful. And then process, and this is where I think a lot remains to be discovered or remains to be clarified. How do we incorporate all of this information into the EMR? I think the Vanderbilt experience that we heard about today is certainly an exception to the rule. We are on an Epic-based system at OSU, and I can't even get a pedigree scanned into the system and uploaded as a PDF. So, there are certainly challenges that we all face with electronic medical records. And how do we incorporate the volume of genomic data that we might have? The reimbursement issues, the efficiency issues, the scalability, again, those are things I think we've heard about before. I'm not going to belabor them. But I do think that they're key things that I think it's a very important distinction to make between what we do in the clinic and what's happening kind of in the research setting. So I would argue, based on what I've just told you, that genomic counseling is pretty much the same thing as genetic counseling. And many of the skills that we use as genetic counselors, or you as clinicians who are doing genetic counseling use, are the same. It's just the scope is different, the approach might be different, and the process needs to be better defined. So within the literature, there's quite a bit out there about the research that's being done to define the informed consent process, for instance, for people going through whole exome, whole genome, or the delivery, return of results. If you went to ASHG last year, that was basically the entire meeting, was about informed consent, return of results. There's also quite a bit in the literature about the clinical setting on pediatric populations and how whole exome and whole genome is being utilized in those patients who are on what we call a diagnostic odyssey. There's very little known, though, of what happens in the cancer clinic, and since that's something I'm interested in, I thought I would share some data with you, because I do think, even though it's a very focused and a very small study, it touches on some of the key themes that we've been hearing about. So this was a study that we did to describe the short-term impact of some events that occurred in 2012 and 2013. I'll point those out to you in just a minute, and how those events changed genetic counseling and testing for cancer. It was a vignette-based survey of cancer genetic counselors across the US, where we assessed their practices and preferences before these events and then after, and what was the impact and what were the factors that influenced practices. So the two events we chose to focus on first was the introduction of expanded cancer panels that was launched in early 2012. Prior to this, we really did not have the ability to test for more than maybe 4 or 5 genes at a time. Now we can test for 40 to 50 if we'd like. And the second event was the AMP versus Myriad decision that DNA segments were not patentable. So this, within a day, if any of those of you who are following this story, within a day, several different labs announced that they would immediately begin offering BRCA1 and 2 testing. And that was a huge game changer for those in the cancer clinic. As we were designing our survey, we also realized that a couple other key events that happened around the time of the patent decision might also influence how people are practicing. One was Angelina Jolie's disclosure of her BRCA status in the New York Times op-ed that she wrote, and then the announcement by Cigna that they would be requiring the involvement of a genetic professional prior to testing for certain conditions. So we launched our survey in November of 2013, and we tried to capture attitudes around all of these different events. This is just a breakdown of the demographics. So within the National Society of Genetic Counselors, there are special interest groups, and we are all on discussion forums together, so it's a great way to survey people. And there were 752 cancer SIG members at the time when we issued the survey, but we required that they had to have ordered a BRCA test in the last month, and they had to be residing in the US. So that cut our numbers down slightly. So we had somewhere between a 20 to 30% response rate. This is just a breakdown of the demographics, nothing surprising there. Just for the next few slides, I wanted to define a couple things for you. So we looked at BRCA1 and 2 sequencing and 5 common rearrangements, and then a reflex to full deletion duplication analysis. So this is kind of the bread and butter genetic testing that had been done up until 2012. There was one laboratory that offered this test, and that was pretty much all you could do. Then I'll also talk about breast cancer panels with or without BRCA1 or 2. So those are panels between 5 and 25 genes that have been linked with inherited breast and or ovarian cancer. And then general cancer panels kind of lump cancer genes together, even though they cause different cancers. So you could have cancer genes for colon cancer, with Lynch syndrome, breast cancer, et cetera, all on the same panel. So this is the first vignette that we presented, and we made this a newly diagnosed 37-year-old woman who had a paternal grandmother with breast cancer, and she had no other known cancers in her family, and she was referred for surgical decision-making. And this, and at least in my area, this is probably the #1 reason for referral. Women having genetic testing to decide whether they need a lumpectomy, a unilateral mastectomy, or a bilateral mastectomy. So this is a time-sensitive type of referral. And it's, as I said, it's a very common reason for referral. We took out the insurance coverage as a factor. We gave this person excellent insurance coverage, so that wouldn't be considered in the genetic counselor's decisions. And then we asked, what would be the first line test for a patient like this, before these events and after? And if that were normal, what would you then do? So here's our data for that vignette in that question. So what you can see is that prior to those events, 99% of genetic counselors and the physicians that they work with were ordering BRCA1 and 2 sequencing with del/dup. Not surprisingly, after, this went down because now we had a lot of different options to choose from. And what you can see here, it was kind of a scattering of choices that people were using. Some people were using a breast panel, some a general panel, some did no testing, which makes me scratch my head a little bit, and then other. So that was the first line test. Then we said, well, what would you do if that was normal? What reflex would you do? And you can see no further testing was done the majority of the time before these events, and then after, it basically cut that in half. And they said that as a reflex test, they might go to a panel, either a breast or general panel, with or without BRCA1 and 2. Here's a couple more vignettes, basically the same theme, where this first case is a kind of a classic hereditary breast ovarian cancer patient with early onset ovarian. 98% would have done BRCA1 and 2 before. Only 50% would have done that currently. Most chose a panel. And then a little bit more complicated family history. And the next case here, where there's colon cancer on one side of the family, some gynecologic cancer, some breast cancer. And in this case, people chose the general cancer panel a little bit more frequently after those events to try to capture, I'm assuming, some of the colon cancer susceptibility genes that might be in the family. So changes to testing practice. I mean, 93% of people said that what they were doing before and after had changed dramatically. And then we wanted to kind of get a handle on what were the things that were important to them in choosing the laboratory for testing. One was, and if you see the top four there, it was really kind of equally distributed between lab reputation, insurance pre-authorization, the out-of-pocket cost to the patient, and then the testing platform, which is kind of what genes does that particular laboratory include in their panel, because there's quite a difference, and they were changing weekly at the time. You can see on the bottom that turnaround time, variant rates, customer support, and the cost to the insurance company also came up not very frequently. It's interesting that the variant rates did not come up very often, because I feel like that's a conversation in the office that we were having a lot about in terms of which lab we would choose, is how good were they at calling a variant benign or deleterious. And then we asked, do you feel like your genetic counseling practice has changed in any way? And which of the following events had the greatest impact? And it seemed pretty evenly split between expanded panels and the Myriad decision, the Supreme Court decision. Then we asked a little bit more specifically, how has it changed? And you can see that list on your left, but I'll read some of these quotes to you. So modifications to the pre-test counseling session, learning how to counsel about testing for a multitude of genes by using a few genes as an example, but not going into great detail about each gene. Spending a little more time on the idea of results leading to some level of uncertainty, either due to a variant or a deleterious mutation in a newer gene. So those are just kind of some of the themes that came out. And what's interesting about this too is these changes are being made in the healthcare environment that we're living in right now, which is pushing for increased efficiency, seeing more patients, billing more, generating more revenue, but we have to do this, we have to be more efficient with more information to share with the patient. So this was interesting. We asked what predicted the change, so we did a couple analyses on this, and there were no significant effects in those factors listed here. So, the genetic counselor's age, how long they've practiced, where they practice, how many patients they're seeing. But the one thing that we did see is that there was a difference depending on where they lived. So these regions 1 through 6 are just regions that historically the National Society of Genetic Counselors used to group people in different regions. And you can see that region 2, which is the Mid-Atlantic region, those genetic counselors were much less likely to change what they were doing compared to people in the Midwest, which is region 4, or people on the West Coast in California. We looked at this just a different way and showed the same results. And I think that's significant because if we're thinking about patient care and access to testing and access to information, it's a little concerning that depending on where you live, you might not even be offered these tests. And how do we think about that as a profession? So the conclusions of the study is that we're seeing huge changes and that we've gone from a period of uniformity to a period of extreme variability in how we're doing what we're doing. It's a running joke in our office that, you know, it just depends on what mood we're in that day, which test we're going to order. And it's a joke, but it kind of does hold true because so many things were changing so quickly at the time, and you really did have to keep up on all these different changes and figure out what was best for your patient in the room. We're doing a repeat survey later this year to try to see if things have evened out at all and if those bars have shifted anymore. So I think the bottom line here is that it's complicated, that for genetic counselors and for physicians and other healthcare providers who are offering genetic counseling services, you know, there's this knowledge base, just kind of knowing your way around the genomics, whatever specialty you're in. This challenge between balancing increased efficiency but giving adequate information, and this familiarity with the constantly changing landscape. So I think that it's complicated, but it sure is fun and exciting, in my opinion. So how is this changing the face of the genetic counseling profession? Well, I think it's expanding roles in many ways. And there are new roles that are popping up, and I think that will continue to happen over the next decade or so. So one new role that's popped up is utilization management. And these are people that review genetic test requisition forms, and they often work for hospital laboratories or for managed care companies. And I don't want to think of them as gatekeepers because I don't really think that that's what they're doing. I think what they're doing is making sure that the physician who ordered the test is going to get the results that they're looking for. And there was a white paper put out, and this is old news, but I think it's still interesting, by ARUP. It's a large genetic counseling lab, or genetic testing lab, where their genetic counselors reviewed test requisitions and found like 30 to 40% of the time the wrong test was ordered. And so it could be something as easy as the physician wanted to order a test for hemochromatosis, and they ordered hereditary telangiectasia. I'm banking on the middle word, HHT. So that one example just shows you that it could be a very simple thing that caused the mistake, or it could be something more like the sister of the person they were testing already had testing, we already knew the mutation, we don't need to do full sequencing of the 2 genes, we can just do targeted sequencing for that mutation. But what they showed is that in a 10-month period, they had a $400,000 cost savings. And it's interesting, I was at the predictive genomics session before this, and I feel like a stick in the mud kind of sitting here talking to you all about we need to save money and we need to be responsible in ordering tests, because I do feel like it puts up barriers for access, which is a theme that I feel many of you are passionate about. But I do think as clinicians living in the managed healthcare world that we live in, we have to recognize that cost is going to be an issue, and that if we want patients to have access to genetic testing, we don't want to do things that are going to put up barriers. And one of those barriers might be an insurance company requiring that a patient see somebody like a genetic counselor beforehand. Some look at that as a barrier, but I think it's in reaction to the number of dollars that are being spent on genomics. So there's also an increase in the number of laboratory counselors. This is data from our professional status survey, and this may not seem like a big change to all of you, but it's definitely significant. But within 10 years, we went from having about 74 people in the lab, so genetic counselors in a lab, either academic or industry-based lab, up to 245. And so if you look at just the growth of genetic counseling profession, this is like 3 times faster than how quickly our profession as a whole is growing. And this was issued in 2013. I think in the last year, this number has probably skyrocketed even more. It's definitely a trend that we're seeing, especially seasoned counselors leaving the labs or leaving the academic setting, the clinical setting, to go to a lab job because it offers a better salary, more flexibility, and it's interesting. So this is a trend that I think will continue. And these individuals in the lab, many of you work with them and know them, but they can be a liaison between the lab and the clinician. They can facilitate variant interpretation with the rest of the team in the lab and putting that into the context of whatever phenotypic information is provided. They can also do management types of positions or product development. So getting back to just kind of the broader implications. So I think I saw a statistic recently that 1/3 of all diagnostic tests were genetic tests. So the number of healthcare dollars that's being spent is increasing, and I think what we don't want to happen is kind of a boomerang effect where payers are cracking down on who they will allow genetic testing to happen on because they want to save money. So I think we have to be just cognizant of that. And I do think we have a responsibility to order the right test for the right person at the right time. What's funny about that statement is, with all the change that's happening, I'm not sure we all know what the right test is, and I think we need to figure that out, but I'll say it for what it's worth. And within NSGC, we've done a lot of work trying to communicate with payers about the benefits of genetic testing for our patients, why it's an important service for them to cover, and we've been working really hard on obtaining billing and reimbursement for genetic counselors. Word about the workforce. So I hear this every meeting I go to, that there's not enough of us. And I think right now, I will say that there's no evidence that we have a shortage of genetic counselors in the US, and we can argue about that. But shortage is defined by jobs not being filled. And I think we are not at that point right now. Jobs are being filled. I think in the next year to 5 years, that will change very quickly. So I think our professional organization is definitely looking at this issue. We're trying to grow the workforce and figure out where the bottlenecks are, and think in the meantime, while we're trying to grow the workforce, thinking of new ways to deliver care, thinking of new ways to interact with our physician collaborators and partners so that we can serve as a consultant, but maybe not as somebody that's going to see the patient at the front end, but maybe be there on the phone or in the clinic as a consultant for when those patients have genetic concerns or questions. So there's a lot of thought. I will say there's a lot of thought going on within our profession about these issues because I think it's going to be very important in the future. So our future challenges are really to, as I said earlier, defining that process. I think you'd all agree with that. Making this scalable, that's a huge challenge. We need to develop practice guidelines once there's enough evidence out there about what these tests can tell us and what they can't. We talked about workforce issues, and I think it's really critical that we all work together, not against each other, to try to come up with partnerships within our clinics that work for our patients. So I will stop there.
Rebecca, thank you so much for that. Covered a lot of ground in short order. Not surprisingly at all, lots of questions here. But we've got some time to dig in, and if folks have any others, send them along, because I know there's a lot of interest in your experience and views. A really good one just came in, and I'd like to start with it because I think it's basic but important. Who actually orders the genetic test? And can you sort of separate out a little bit the relative roles of the counselor versus, say, the referring physician?
That's a great question, and it's really relevant right now. So genetic counselors have not had licensure in all states, and we're working very hard to obtain that. So I think there are about 16 states that issue licenses now. And the issue of ordering a test is really something that is put into the regulation. So if your bill has in it that you're allowed to order tests, you can order a test. So in the state of Ohio, we just achieved licensure last year. Our licensing board is the state medical board, and the physicians that we worked with when writing the rules and regulations were comfortable with us ordering tests as long as we had a collaborative agreement with a physician. That's very well defined, and that can be interpreted from institution to institution, but basically it's to make sure that we're doing the right thing and that the physicians are in agreement with what we're doing. Many states don't have ordering language in their law, and so when we ask the question in the survey, when we say, what would you order? the implication is, what would you and your physician partner order? And the name that's going on the test request form in those instances is the physician. It's the physician that's ordering the test. But the counselor and the physician work very closely together to try to figure out what test they think is appropriate for the patient.
So they work very closely together determining the test. Then when it gets to the actual counseling piece, are there some best practices, or I'm just curious, in your experience, is there ever a doc who says, I want to be in this conversation, or I've actually told the patient this already?
Yeah, and it really depends on where you work and what service delivery model you have. You know, I work really closely with a physician. I don't have to work closely with a physician based on my licensure law, but I do. She's in the room with me during many of the patient counseling sessions. I think it's critical. We cannot practice medicine, so we can't make medical management recommendations. So once those test results come back, we can certainly put them in the context of the family history for the patient, but it's up to the physician to make the medical management recommendations and then to refer the patient on for those services.
Another question, do genetic counselors discuss the financial implications of testing?
Yes. Unfortunately, we spend a lot of time. It's probably one of the only healthcare practices that I can think of where we sit there and talk about cost with patients for at least 10 to 20 minutes, because that's a huge, we think this should be a standard service for people, but I think our patients still think of us as an extra or a special, you know, it's a special thing that they're doing. That culture shift hasn't moved all the way over yet. So I think we do have to spend a lot of time with them talking about out-of-pocket cost.
Okay, so the discussion is also around what their insurance covers and that sort of thing.
Whether they meet medical necessity criteria, what's the cost of the test, what's the expected out-of-pocket. And I will say many of the testing laboratories do a great job of helping with that. They have entire group of staff that will call the insurance company and do that pre-authorization.
Okay. Another one here asking if you can clarify the differences between lab-based genetic counselors and clinic-based.
Sure. So clinic-based counselors, the way I define them, are people that are actually in the clinic seeing the patient face-to-face or over the phone. Laboratory counselors serve many different roles. Some of them do talk to patients. It just depends on the lab. Many of them, however, are kind of more behind the scenes, where they're part of the team that's working on the variant interpretation. So they're going to go out and find the literature about that particular variant, and they're going to look at the phenotypic information, put that into the context of what variants they might be seeing. So within the laboratory, there's lots of different roles they can have. Many of them are what I would call behind the scenes, though. They're not actually interacting with patients, at least on a daily basis. But many of them have that experience coming into their position, which I think is invaluable, because having that background, that clinical background, and knowing kind of what is important to patients when they're in the lab is critical.
And you brought up the workforce issue, which I think is a good one, so I wanted to follow a little bit on that theme. I mean, first I'm curious, what does it take to become a certified counselor? I think you mentioned to me that at least now there are more opportunities, is that right?
So it's a 2-year program, typically a master's program, and then you can sit for the board exam. And when I first graduated, you could only sit for the exam every 3 years. So if you came out on the wrong year, you'd have to wait an entire 3 years to be certified. Now it's offered twice a year. And it's a computer-based test for certification. And then in the states where licensure is available, you can become licensed.
Okay. And are we anticipating that there are going to be ongoing discussions around scope of practice, and are there some debates coming up in any of the states? I certainly see that in other aspects of healthcare these days, because there is so much cost pressure, because we have a lot of newly insured individuals who suddenly are going to have access to care. There's that demand.
Sure. I think for us, from a national organization, we have no desire to change our scope of practice at this point in time. We're pretty happy with our scope of practice, and we feel that the partnerships that we have with our physicians, it's a great match. It's a great meld, and that we complement the services that they offer, but we don't replace the services that they offer. So while I think outside groups might want to look at our scope of practice and may be concerned about it, we feel very comfortable with where it is, and we have no desire to kind of expand it. When you look at the history of other healthcare providers, like nurse practitioners, PAs, there was a little bristling going on about scopes of practice. And I think for the genetic counseling profession, when we're advocating on the Hill for our bill for CMS to recognize us as providers, that scope of issue never comes up because we have no desire to change it.
Okay, and I think that you answered this when we were discussing cost and insurance, but just to be positive, question, do genetic counselors obtain pre-authorization for the patients, and is that consistent across the board?
I would say it is consistent. It just, in some disciplines, the laboratories do that for us. It's in their best interest to make sure the patient has good coverage so that they can send the test to that lab. So within the cancer section of the genetics world, all the labs do that for us. I'm sure, and I know that within other areas like pediatrics, prenatal, adult, sometimes it's the counselor actually doing that, or staff within the office doing that for the patient.
Mm-hmm.
Yeah.
You were also talking a bit in your presentation about some regional differences that came to light in your study, and I'm wondering if you have some insights into why that was.
We've talked a lot about that. We don't know. One possible explanation could be that patients within those certain regions, the uptake of mastectomy, because this was a very focused study on breast cancer and BRCA1 and 2, maybe the mastectomy uptake rates in those regions are higher, or the surgical decision-making population is higher in that mid-Atlantic state, those states. And for that reason, they need the information very quickly. And so they can't wait 12 weeks to get a panel test back, because those panel tests in some labs are taking 12 weeks. In many labs, they're taking 2 to 3 now, but this was a year ago. So it could be just patient behaviors, and this is kind of a downstream effect. I also think that within that, I've talked with some of the people in those states, and many of the big academic centers there just do not believe in ordering tests where we don't have data to back up what we're telling patients. And so it could be that as well.
Huh, interesting. So I confess I wanted to ask you this, but somebody from the audience, thank you, sent this one in. What do you think of the FDA shutting down direct-to-consumer genetic testing, such as 23andMe?
Yeah, I think I think that's something that we all saw coming, just from some of the murmurings we were hearing.
Mm-hmm. And in fact, I think there were some warning letters.
Well, there was many warning
built
letters,
up
but
to that.
Yeah.
Mm-hmm.
So I think it's, I certainly think that the intent to protect our patients and to make sure that patients aren't harmed is a good one. I also worry, as a private genetic counselor, that they won't get the nuances and they won't get the details.
A consumer when they receive?
No, the FDA.
Oh,
I worry that they will not understand the complexities of it when they're making determinations about what should be regulated. And I feel that that might be another barrier for people who want to have, for instance, DTC testing. That just puts up another barrier for them.
Right.
This is my private, personal opinion. So I think it's kind of a double-edged sword.
It does seem to me, though, that we're going to encounter more and more of these types of issues when you just think about how much more healthcare is in the hands of the consumer. We're spending more of our own money on healthcare. We're making more of our healthcare decisions. We were talking earlier today about who owns your data. So I would think that your field is not going to be immune to these desires by some consumers.
Right, absolutely. And to me, I think one of the things we need to start talking about is it's not an either-or. It's not an either-or system where you can only do DTC with no genetic counseling up front, or you can only do traditional medicine. We can do both. We can do it all. We just have to work out the process and make sure that for each single patient, as they're going through that process, there's not a lot of collateral damage for them. Mm-hmm. That they're getting the information they need, and they're getting it in a way that's helpful for them, and from a place or a person or a website that is right for them. So I think we need to be open-minded about that.
Mm-hmm. Science question here from the audience. In terms of whole exome and whole genome sequencing, physicians are often the first person to talk to patients about testing options. Does this initial conversation with the doctor make non-directive counseling difficult if the patient then is already expecting to have the test?
That's funny, because one of my patients, my first whole exome patients who came in, was and it was a very influential physician at my hospital who sent her in and said, I want whole exome sequencing for her. She had no family history of anything.
Wow.
she had, the age-related diabetes, things over age 60, no cancer, but she was worried about breast cancer. So I went in thinking, she's going to really push me on this. I'm really going to want it. She had the means to pay for the test herself. And after a conversation, she actually was really comfortable with just doing BRCA 1 and 2 testing. Now, is that the right test for her? I don't know. But that was, her main concern was the most common forms of inherited breast cancer, and that's what she chose to do.
So I'm going to step in here with a super dumb question, because as you're describing that, I'm guessing that your role is to play it straight down the middle, just the facts, ma'am? Or are there instances where you're kind of leaning in one direction with a patient?
I think our profession is moving a little bit more to the directive side. I think we're entrenched. That's kind of our culture, is to be non-directive. And I think there are many situations where that is absolutely appropriate. It's actually necessary to be non-directive. But I do think, there are some instances where we can chime in and give them a little bit more background, and give them a little bit more framework for which to think about it. Mm-hmm. And for her, it was really, this might open up Pandora's box for you. That's okay. You might get information that you weren't looking for. How do you feel about that? And she just didn't want that. Mm-hmm. That was her personal choice. Mm-hmm. She didn't realize that when she first talked to the physician about it. So,
yeah. Another one here, bringing up from our earlier conversations today, in which we were talking about coverage of life insurance, long-term disability insurance. Do patients seem concerned that their ability to get those other types of insurances if they undergo this testing? So is that a topic that comes up at all?
So I can only answer from my experience, and I'm mostly seeing adults over the age of 40 for cancer genetics. So it's a totally different population than like a pediatric setting. So most of them either have that stuff in place. They're not concerned about disability. They're concerned about life insurance, but they already have a policy in place. The time where I see people putting on the brakes, it's usually when a parent comes in with their young 21-year-old daughter to have BRCA testing, and we talk about it, and they say, oh, can we not do this until I have stuff in place with her? And then she goes and gets her policies in place, comes back and gets tested. So it is a conversation. I would say it's not as much of a concern as health discrimination used to be when we first started doing genetic testing, where we couldn't even get people to come through the door.
Right.
Yeah.
Right. And a good observation from our audience, just to make certain, maybe you can really clarify the role of the clinical genetic counselor and how perhaps you're getting referrals. Mm-hmm.
So within the cancer clinic, at least in my institution, and I'm sure it varies from place to place, it's mostly specialists referring in. So it's our surgical oncologists in the area, it's our medical oncologists. I would say for breast cancer, it's the OBGYNs, and then probably a small proportion of PCPs. So we've done a lot of targeted outreach in our area for that.
For those specific areas.
Yeah, just to let them know that our services are there. And within the Columbus area, there are 3 different genetic centers. There are 3 different places you can go for genetic counseling. So we don't get a lot of referrals within the city outside. I mean, it's kind of if you're an OSU patient, you're an OSU patient. Outside of that area, it's kind of a free-for-all. Mm-hmm. Yeah. Mm-hmm.
And I thought we might just sort of close a little bit where we were beginning in terms of workforce demand. Is it an exaggeration to say that there's sort of a tsunami heading your way in terms of demand? I mean, what do the next 5-10 years out look like? And are there some creative ideas around how you're going to handle this demand?
Yeah, I think we're worried about that. We're looking at that. I think there's one distinction that we've been talking a lot about is the demand for genetic services versus the actual utilization of genetic services. So we may look at the numbers and say, okay, this many Americans need genetic counseling services, but that's not going to equal the number of people that get or want or seek genetic counseling services. The demand in our mind is going to be much greater than what is actually utilized. Mm-hmm. So I think that's where there's a little bit of a disconnect, is that we think everybody needs our services, but they probably don't, and they probably won't come see us. So that makes us feel a little bit better about it. But as I was telling you earlier, one of the things that our organization's looking at is a workforce analysis to actually get a good handle on what is the demand, what is the utilization going to be. And it's going to take, it'll be very complicated because I think we have to look at not just genetic testing in the diagnostic setting, but if we're looking long-term, we need to look at genomic testing in the kind of preventive care personal setting, which is a much broader swath of the population.
Right.
It's not just the sick patients, it's everybody.
I suppose, we can end on maybe a little bit of a bright note, silver lining to that, which of course is, that may mean a lot of good economic opportunity and job opportunities. I mean, this is a growth field,
right.
And other areas of healthcare are going through those cost pressures. So maybe we'll look at the silver lining.
Yes, we try to.
Please thank Rebecca Nagy for spending time with us.
Thank you.
Thanks, Rebecca.